Welcome to Regulated and Relational, the bi-monthly podcast brought to you by the Attachment and Trauma Network. Ginger and Julie are joined in the studio today by Dr. Stan Sonu, a pediatrician and internal medicine doctor whose expertise includes adverse childhood experiences, relational health and resilience, trauma-informed care, medical legal partnerships, and advancing health equity. Let's jump right in.
Hello, everyone. Welcome back to Regulated and Relational, our podcast produced by the Attachment and Trauma Network. I'm Julie Beam.
And I'm Ginger Healy.
And we're excited to share with you from both our personal experiences and our professional knowledge what it truly means to be attachment-focused, trauma-informed, and how we can help children impacted by early childhood trauma. Today, we have an amazing expert guest with us in the studio, and we cannot wait to introduce you to this person. Ginger, tell us more.
I am so excited to introduce you all to Dr. Stan Sonu. He's an associate professor of internal medicine and pediatrics at the Emory University School of Medicine in Atlanta, Georgia. He's deeply committed to teaching professional and public audiences on adverse childhood experiences, ACEs, relational health, and resilience in primary care, trauma-informed care, and medical legal partnerships, and health equity. In addition to supervising internal medicine residents at Grady Memorial Hospital, Dr. Sonu provides primary care for children at Hughes Spalding Children's Hospital. Additionally, he serves as the medical director for Child Advocacy at the Children's Healthcare of Atlanta. In this role, he oversees programming for Strong for Life and helps manage the Health Law Partnership, an interprofessional medical legal collaborative addressing health-harming legal issues. Dr. Sonu obtained his medical degree at the Medical College of Georgia and completed a residency in combined internal medicine and pediatrics at Rush University Medical Center in Chicago. He completed a fellowship at the Cook County Preventative Medicine and Public Health Program and also obtained a master's in public health at Northwestern University. Beyond all of these titles and activities that fill his bio, Dr. Sonu is a son, a spouse, a parent, a friend, an Asian American, and a person of faith. He strives to live each day in the reality that his worth is found in humanity, not in his professional or educational accomplishments. In his free time, you can find him drinking coffee, reading a book, enjoying engaging conversations, and spending quality time with family and friends. And I had this great honor of speaking with Dr. Sonu at a conference in Georgia earlier this year, and just about attacked you after you spoke and said, "Oh, we need to collaborate and get to know each other. And can you please be on our podcast?" Knowing how incredibly busy you are. And after reading that bio, I'm sure everyone is thinking, how can you even, spend time doing this? And so it is an honor to have you here in the studio, and welcome, Dr. Sonu.
Thanks so much. I'm the one who's honored to be here and sharing this time with you all. So thank you for that warm introduction.
Well, we are definitely pleased to have you with us, and I'm super curious about what you consider good coffee, and maybe we need to go for coffee someday.
Strong opinions.
We could, but I really want to start talking so that our audience can get to know you a little bit about how you got here. I mean, being a pediatrician and doing all of these things doesn't necessarily imply a deep understanding of ACEs or an importance of relational health. How did you get to this expertise?
You're absolutely right, Julie. This is not a topic that I was taught in medical school or most of residency.
Mm-hmm.
So as Ginger, read off my bio, I am both a pediatrician and internal medicine doc. So that means clinically, I see patients from the newborn age all the way through the elderly years. And so I'm privileged to care for people across the entire age or life course spectrum. And I think that has shaped my perspective of health in many ways. But to answer your question, so I didn't learn about any of this in medical school,
Mm-hmm.
although I had an earnest intention to learn a healing practice. And to be honest with you, my residency was 4 years long. In my last year, when I was entering my fourth year, I didn't realize it at the time, but I was pretty disillusioned when I look back. I think I felt duped in a way.
Mm.
I had worked so hard, I'd studied so much to become excellent or as excellent as I could be in clinical practice, treating patients at the bedside, learning illness scripts and memorizing drugs and synthesizing information to coherent assessments, all that.
Mm-hmm.
And I even when I was successful in helping someone's diabetes or blood pressure or this infection that was causing sepsis in their body, even though when I was successful in helping someone's health improve, very few people were coming back to me saying that they were flourishing and thriving.
Mm.
Very few people were coming back to me with words and language signaling that they were healed or healing.
Okay.
And in some ways, I think on my worst days, I felt like I was really good at managing conditions, managing problems, but I wasn't seeing that benefit translate to people's lives improving. And so it was about 3 months away in my last year of training, 3 months before I was going to graduate the program, after which I could be cut loose to go practice anywhere. When I call it serendipity, sometimes I call it divine serendipity, but I just attended this Grand Rounds lecture by Dr. Marjorie Fujira, and I'm keen on saying her name because she played a really important role in why I'm here today. She was giving this Grand Rounds talk for the Department of Pediatrics on adverse childhood experiences, and I had never heard even that term before. I'd never heard the term ACEs, and at this point, I'm in year 8 of my training in medicine, and this is the first time I'm hearing this topic. Long story short, I was blown away by her presentation. I was mystified. I was dumbfounded. I was also frustrated, and if I'm honest, I was in a bit of disbelief. I was skeptical. How could I have gone this long in my training and not heard about this
Mm-hmm.
research, this connection between adversity in childhood and all of these undesired health outcomes in adulthood, but not just in adulthood, also through the through the childhood years as well. And that frustration kind of morphed into curiosity, where I just had to read about it to see if is this really true? Did I really miss this? And the answer was I absolutely missed it. And it absolutely was true. But around this time it was 2015, middle of 2015, and a lot of work around ACEs had already been done and replicated in other communities, other samples, other research studies, other kind of nuanced designs, and all of the consensus of this research was so convincingly clear that it showed the same thing the original ACE study showed, that yes, childhood experiences do matter and affect our health over the life course. So that was kind of the first pivotal moment for me. I think around that time, I knew this had changed the trajectory of my career. I was not going to be only a practitioner of medicine, but I felt this conviction that it can't just be me that feels this type of way. Everybody needs to know about this. And what's interesting is that it like instantaneously changed my practice. I
Mm-hmm.
won't say it was overnight, but over a period of some weeks to months, it really changed the way that I approached patient care and how I viewed people.
Mm-hmm.
It gave me language and concepts to understand why certain behaviors that we are quick to label in medicine as dysfunctional or non-compliant or
Right.
problematic in some way. It gave me concepts to understand substance use. That's a big one,
Yes. Yes.
where
Yes.
something like cigarettes or any kind of substance
Right.
really that's addictive actually has it's self-medication, right? It's
Mm-hmm.
self-medicating. It's a process of self-medicating, not the way that it's packaged and taught to us as it's an issue of willpower or it's an issue of health literacy and or someone
Mm-hmm.
who doesn't care about their health or is not ready to make a change. That was a really big aha moment for me as well. And yeah, so it really changed, it shifted how I started talking to people. And then what I noticed was I finally felt this kind of connection with my patients that was kind of just buried under the surface, but now it was really coming out. And
Mm-hmm.
and then patients would say, I've never had a doctor talk to me like you've talked to me before. There's something different about you, or you're understanding me in a way that I've never felt understood. And a lot of
Mm-hmm.
that was affirming and certainly kept me going. And yeah, from there, starting with the topic of trauma, it's as you both know, it's this ecosystem of knowledge that can go into trauma-informed care and relational health, and it can be applied in all sorts of different settings in education and healthcare, in the justice system and social services.
Yes.
And so I just became really entrenched in the content and self-driven and got my hands on a lot of Dan Siegel books, Dan
Awesome.
Siegel's
Hmm.
books around interpersonal neurobiology and yeah, I feel like I'm still on that wave right now where I'm just avidly reading as much as I can on this topic and trying to figure out ways to repackage it in a way that makes sense for the medical community.
Right. Right.
That's where I want to go to next, because I mean, you're hitting on so many important things, but even you saying that you're still continuing on this journey, I feel this way too. Like, this field of neuroscience is still exploding. We're learning so much more, and this interpersonal biology. And I always think every time I speak about ACEs that someone's going to go, "Oh, do we have to hear it one more time?" But I find that people go, "What? Tell
Hmm.
me more."
Mhm.
And that's what you're saying too. So this work is so important, but I would love to hear like how that translates in your day to day when you are meeting with patients. I mean, you're already talking about you see them differently, you ask different questions, they have a different experience leading you. But I just, this is the first time we've really talked to someone from this medical perspective of seeing patients day to day. And I just want to know more, because I think at the end of all this, how do we spread your work, in your
Yeah.
field, all
Yeah.
of that,
Yeah.
like, oh,
Yeah. Well, if I can go meta for a second, I think the fact that I am the first medical or somewhere on this side of healthcare to be on your podcast,
Mm-hmm.
it's an indictment on us really that there's so few practitioners in Western medicine or allopathic medicine that
Mm-hmm.
are aware of this because it hasn't yet. I will say that there has been a lot of progress that's been made, efforts that have been made to expose students, not just in MD programs or DO programs, but also, PA school, nursing students, pharmacy students, et cetera.
Mm-hmm.
There's been a lot of progress, but it's not widespread to the level where it's, systematic. We have a long way to go. I think the way it shows up, um, and this is kind of a false dichotomy, but I do think about how it applies to adults versus how it applies to children and parents. So for adults, the question I got early on was, well, trauma has already happened to people, so what's the point of talking about this? You can't prevent it.
Mm,
And my answer to that is, be that as it may, yes, trauma has already occurred. Many people are still walking around with these wounds that they've incurred in childhood
right,
that are just covered with scar tissue. But if you just look under the surface, that wound is infected and it's getting worse. It's causing other problems, and it's been a source of dysfunction in that person's life, whether they know it or not.
right.
And knowing that actually can change how you show up at the bedside. For when I see adult patients, I work at a hospital called Grady Memorial Hospital. It's a big safety net hospital system in downtown Atlanta. It is just an incredible place to be. It's very challenging. Don't get me wrong, but there is a pride for people who work there. There is a pride for people who were born there. I love when I hear from patients, I'm a Grady baby. So people are very loyal to this hospital because it's always been there to serve and meet the needs of the community in Atlanta, especially for those who have been underinsured or uninsured, or
Mhm.
have had other financial constraints. And at a place like Grady, being trauma informed has been so instrumental for me, both in terms of my, I think, efficacy or my effectiveness as a doctor, but also for my own well-being. I think you've probably heard the phrase, and your listeners have heard the phrase, it's not what's wrong with you, but
Mhm.
what's happened or who's helped you or what's strong with you. And that really is the frame of mind that I go into the patient encounter. I also hold this value of having unconditional positive regard. And I think those two frames, when you express those two concepts through your words and your body posture and the way that you talk to people, it can soften people. And I can tell you, I have countless examples of people who, when I first met them, were hypervigilant and they were kind of lashing out, kind of
Mhm.
in full expectation that I would be another doc to dismiss them, to not listen to their concerns, to somehow rationalize or intellectualize why their problem wasn't the problem. And when when I would really try my best to be understanding and listen patiently, but listen with intention and attention,
Mhm.
that hypervigilance response, that self-protective response
Yeah.
would kind of fade, and then I would see the real person, and then we would get to connect on that level or that wavelength, and and that's what makes the job so rich. That's what makes the job so incredible and so fulfilling when you earn that trust of someone who's been suffering and who has been hurting, who has a physical need that really connects to an emotional need, and they feel seen by you. So that's the adult world. I have many stories of that I can share. And in the pediatric world, I think I love the children, of course. Children are incredibly resilient. They're primed for resilience in a way. I love talking to parents, though. As a parent myself, I think that's a place where I can really empathize with the
Mhm.
challenge of parenting in the 21st century. And so I think for pediatrics, the way systematically that I approach it is having a two-generation approach where the child is not my only patient. The Like it or not, the parents are someone I care
So
about
smart.
too.
Yeah.
And the parents' well-being is the child's well-being. The parents' mental
Absolutely.
emotional well-being is the child's mental emotional well-being. And when parents, I think, pick up that I actually care about their well-being as much as I care about their child's, that also can soften the ground a bit too, and we can connect on that level. And
Mhm.
so I'm quick to kind of gently suggest or nudge the parents, hey, I think you have exhausted yourself taking care of your baby. I can see that you really love your baby. but I can tell you're exhausted too. And and through that conversation, I'll just very gently, not hopefully not intrusively, but just gently nudge them to prioritize their own health as well. That it serves two purposes, both it's for their well-being, but also their babies.
Right. Exactly. No, I love that. And I mean, that whole example you gave, even though you were talking about adults, it's so much the way we watch the educators in our world do this trauma-informed care with the students that way too, the whole connectivity. And the whole concept of that intergenerational health and intergenerational thriving and resilience building that can take place to counteract any of the adversities that are there.
Mm-hmm.
It's beautiful. That's what we would want all medical professionals to know and do. It would be
Yeah.
and in some ways it might be harder because you have to put your own who you are out there in the world, but in other ways, like you kept saying, it's so much more enriching, right?
Mm-hmm.
So
Yeah, as you say that, it makes me think about how the public has perceived, conventional Western medicine, and how that perception has changed over the last century, to the extent where I think we have lost a lot of the public's trust, if I'm being very blunt about it.
mhm.
And I don't think, yes, there's a lot of misinformation and there's disinformation out there, but I don't think that's the entire story of why trust has eroded with healthcare. I think a big piece of it is a person goes in and they have something hurting, or they feel sick in some way, they don't feel right. And it's not even that they're dismissed necessarily, it's that they feel systematically dehumanized.
Mhm.
That instead of their providers seeing them as a person who has a life, who is a son or daughter, who is a sibling, who is a parent, who is embedded in a community, they feel like they are just words on a page, or they're
Mhm.
another row on an Excel spreadsheet. They're another problem to solve. And once that problem is solved, then they're asked to leave the hospital. And I think part of the reason we feel this tension from the public is there's a reaction. There's an understandable reaction against that. And so I think in some, the big picture, another thought I have is our healthcare industry has an identity crisis right now.
Mhm.
These market forces have put us into a corner where we prioritize efficiency and throughput over, are we really doing right by people? Are we taking care of people holistically? And I think, yeah, I think people feel the erosion of compassion, um,
Mhm.
and humanism.
Yeah.
So that, yeah, it just made me think
I,
of that as you were
I
talking.
love that as you're talking because we actually hear that similarly in schools, that
Mm,
schools are the pressure on schools are test scores and academics and the goals, and not necessarily seeing the children for who they are as a whole child sort of scenario. And it's very similar that when we prioritize those systems, in that, like we let the systems prioritize all of that, the efficiency and the, and the steps of the process versus the relationship and the connectivity between two human beings, it really does shift things. And
mm,
as a personal aside, I followed my primary caregiver all over the metro area because she listens to me. And I
mm,
know that, I mean, I'm willing to do that because we can have a conversation, and I don't know, I'm assuming she remembers the detail about me. It might be in my file, it might be that it pops up but whatever it is, it feels like she knows and cares and will work with me in that way.
Hmm.
And that's incredibly valuable. I guess as somebody who's been doing this work for a long time, to me that's incredibly valuable no matter what your profession is, that you can.
Absolutely.
Yeah. So talk to us, because I did a little homework on you as well and heard a TED talk where you used the word systemic empathy. And I
Oh.
was fascinated with the words together, the idea and the concept of the systemic change that would bring us to be more empathetic. Talk to us a little about that.
Hmm. Yeah, it's a concept that I didn't invent. There was his name slips me, but a law professor in the 80s wrote about it
Okay.
in the context of how the practice of law should be, that our legal system should be an expression of systemic empathy. But at the time, I did think, oh, I've never heard this term before. And I think when the term came to mind, I was thinking, my goodness, there's so much research now that points to the the unmistakable importance of empathy as a healing tool,
Mm-hmm.
and empathy as something that has an evidence base to rationalize why it should exist. Now, at the same time, I was like, it's ironic that we need to have evidence to rationalize empathy,
Yeah.
but it kind of that's the state we're in right now in our
Yes.
society, where I have to make a case for
Yeah.
spending time with the patient. I have to make a case for slowing down and
Mm-hmm.
thinking about a person holistically. And as I was sort of reflecting on the evidence-based nature of it, I realized, well, it's not just healthcare that needs this.
Mm-hmm.
We need to see the sort of practice of empathy increased in all sectors that serve human beings. So
Yeah.
it's not just healthcare, but it's, to your Charles' point, education,
Mm-hmm.
the justice
Yes.
system, the legal system, our
Mm-hmm.
social services, even the way we do business. I think it's missing that piece that we are people, and humans, we need each other. We are designed, as you both know very well, we're designed to be connected with each other, and not be atomized, and not reduce each other to units of productivity or units of attention.
Right.
But we need systems that cultivate and help us see the human in one another. And I thought, by saying, hey, we need to see we need to see systems of empathy emerge,
Mm-hmm.
that it was kind of pointing to, well, we have research to back this up. This is not just an idea that I think is nice and makes me feel good about myself, but this is like, we have research that says, hey, grace in an encounter is so healing. Grace is healing.
Yeah.
Unconditional positive regard, like that is what melts away people's self-defense mechanisms. And and like I said, there's evidence to sort of support taking that position. But I think of systemic empathy like a North Star. Like, it's not this outcome to achieve. I don't think it's an
Mm-hmm.
achievable outcome. I don't think about it like that. I think about it as a lens, or a direction we're headed. Uh,
Mm-hmm.
and and for me, that kind of takes the burden off, us having to achieve an outcome by a certain period or a certain length of time. These systems that we operate in, you take education or healthcare, are massive. They're massive, massive systems.
Yes.
And I am for the slow but meaningful change that has some integrity behind it, that's not just looking for short-term or myopic goals, or outcomes that just make me look good for a period of time. I want to invest in work that will create lasting change. And so, yeah, just, I guess it takes the pressure off me to do that, but I think it's important for those of us in this field to also not want to seek our own glory for it. Like, it's not about making my name, I'd rather do the work and
Right.
and and be unknown and behind the scenes if
Yeah.
it means that systems actually change than become well known in a short period of time because I'm talking about some fancy idea, you know.
Mm-hmm. Mm-hmm.
So do you have any advice or like next steps or something? Because it does get overwhelming when we do talk about system change, but I also never want to get stuck there. I feel like there are
Hmm.
some maybe actionable things that we can do, and so do you have any thoughts on that, whether it be those in your field or us as patients coming to doctors? Because I think we get intimidated, and we defer to those in the medical field. But I like the idea of us advocating, for what we need and pushing on that a little and educating the doctors, so
Hmm.
give us some ideas on what you think we
Yeah.
could.
Oh, a lot of thoughts there. I will say the reason that dehumanization is so prevalent today isn't because healthcare is full of bad people, bad, selfish, money hungry people. It's not about intent. It's actually a lack of intent that's driving
Mm-hmm.
the system right now. That's created the system that we're in. It's a lack of intent. And so I think the first step, at least for the provider side, is we need to, it starts with self-regulation, but actually self-regulation isn't step one. I think it's a middle step, and we have to go even further back than self-regulation and think about where is our attention being placed right now? Am I in the master control of my own attention? And so to get really granular, one of the things I'll challenge medical professionals to do is to take inventory of how often they're on their phone. Because these days, that our attention is actually co-opted. We're not in control of our own
Yeah.
attention. It's controlled for us. We don't get to point the arrow of our attention anywhere. It is being drawn out of us because of the way smartphones and social media have been engineered. And so I'll ask people the next time you park in a parking garage and walk to your clinic or walk to the unit in your hospital, can you do it without looking at your phone once? And I can't tell you how many people have come back to say, I tried it and I'm really mad at you because that was really hard. And I didn't know how reflexively I was looking at my
Yeah.
phone. And then I'll say,
Yeah.
great, but we have to do this non-judgmentally. So when you feel the impulse to look at your phone, just reach for it. Like just notice what that feeling is. Just notice
Mm-hmm.
it. And then from there, we can sort of build this capacity for self-regulation, which can deepen our own self-awareness and then allow us to be present in the encounter and really treat people out of our value system. So, that's kind of the starting step there for providers and for patients. I I think yes, I would absolutely empower patients to advocate for themselves. I sigh because I think I hate to burden patients any more than they already are because they're the ones that show up to our units and our clinics for a need that needs to be met. Not
Mm-hmm.
and I'm reluctant to say you got to do one more thing to present yourself better, but if I had to suggest anything, I would say something that can wake a provider up to your humanity is if you see their humanity. And saying something like, um, if they're like 30 minutes behind schedule and they come in the room, a patient has every right to be frustrated at that.
Right.
But instead of frustration, if that doctor was met with, you must be working really hard today. And I want you to know, like, I'm just glad you're here. That again, that can melt away hypervigilance even on the physician side because physicians absolutely have the same self-protective defensive mechanisms that anybody else does.
Yep.
We're
Yeah.
just in a position of authority and power, and we can hide it better. We can intellectualize it,
Mm-hmm.
but um, but nobody isn't human.
Right.
Everybody still is human
Right.
and would be struck by that depth of understanding from a patient. So
Well, I think it shows so much compassion and it and that reciprocity of we want them to look through a different lens, but it would be great for us to look at them through that more humanized lens too. So I
Right.
think super powerful.
Right.
I loved that.
Well, I don't want us to end this episode without talking about the health law partnerships and what you're
mm,
doing in that arena and why that is so important, because it is. So tell us what led you to that path and what's actually happening.
the health law partnership, that is one of my favorite things that I get to do. It's the feather in my cap. It is, just to explain what it is. So we are a team of health professionals that team up with attorneys, and we address health harming legal issues or social issues that might require a legal intervention for families that are seen at children's.
Okay.
And we have certain criteria for families we can help. Our criteria is that that the patient has to be someone who's been seen at one of our children's facilities, and the family income level has to be at or below 200% of the federal poverty line.
Okay.
If the family meets both those criteria, then they can receive representation from our attorneys for that issue for as long as it takes, and it's
Okay.
free. So the most common cases that we end up helping families with involve housing, so rent disputes, or a landlord who is supposed to be, managing Section 8 housing or housing that was obtained through a voucher program, but they're not responding to mold or leaks or plumbing issues. So housing is a big one. We also help with educational issues, so IEPs
I was just
that
going to
seem to be
ask you that
falling through
because
the cracks. Yeah,
yeah.
IEPs that haven't been done yet, despite
Mhm.
having been requested. Um, Schools that have not implemented a behavioral health plan. Schools that have threatened to designate a child with truancy when that child has been out of school because they had leukemia.
Mhm.
Um, we also handle a lot of disability or SSI cases or Medicaid
Okay.
cases, and I can share one story that kind of highlights why I'm such a fan of this. So we had this child who was born with sickle cell disease, and that's it's a blood condition that
Mhm.
is characterized by the sickling of red blood cells that can get stuck in organs. It can cause strokes, but it usually causes really, really severe pain
Mhm.
episodes intermittently. And children as young as 2 will start to experience excruciating episodes of pain. And when it's not able to be controlled well, it will cause organ damage in various organ systems. And one of the most common places that can cause damage is in the kidneys. So we had this child who was 9 at the time. She had sickle cell disease. Her sister did not. The child had already had a stroke and was starting to show signs of kidney failure. And her hematologist discovered that the patient's sister was a perfect bone marrow match for a transplant, which would be curative, which would cure this child's sickle cell.
Mhm.
And this is a new therapy that had come out, in the prior 5 to 10 years, but it was very, very expensive. So the hematologist did the entire workup and uh, got to the point where she was sure that the sister of this patient was a good bone marrow match, that it would be safe to do the procedure, and then sent the prior authorization to the state Medicaid office and was rejected, was denied without explanation. And this hematologist was very intrepid. Like she wrote letters, she tried to call people at the office. She just couldn't get a hold of anybody, couldn't get a response. And then eventually the child was referred to help, our team, and one of our lawyers got right on it and got in touch with the Medicaid office, found that they actually had outdated records that seemed to suggest the child had less severe disease than she had. So within a month, the denial was appealed, was reversed. Medicaid office approved the bone marrow transplant. The child got it, I think, in January of 2023, so a couple years ago now, and her sickle cell was cured. And
Wow.
and so both in terms of the health impact, the health trajectory that this attorney's work shifted, and the ROI, the money, the cost that was
Hmm.
saved to the system
Yep.
are immense. And,
Yeah.
and so this is the kind of work that we do. Like that, this hematologist could not have done what this lawyer did,
Yep.
Right.
despite her best efforts, despite being passionate, despite being committed. We just needed the expertise of a trained, attorney,
Right.
a professional to understand what was going on. But the attorney was also fueled by understanding the stakes of what was going on because we were
Right.
like, this is a big issue.
Yeah.
This is serious. Like, this is the ramifications of if this child can get a bone marrow transplant are immense, and it is rare to have a perfect bone marrow match within the family like that. That's an opportunity you cannot just let fall
Hmm.
through your fingers. So that's one of my favorite cases to talk about, but that's the work that we do. We're kind of in this gap, in this niche space where the at the intersection of social issues and health, where if we can get families what they need, it can really change the trajectory of their child and family
Yes,
in a
it
more
can.
positive way.
It can. Oh, wow. That is fantastic work. No wonder it's a feather in your cap.
Oh, I
Yeah.
love it.
Yeah.
I love it.
So super powerful. Julie, don't you think we need to clone Dr. Sanu?
I do. I do. I'm just thinking about all the other ways and times I want to talk with him and hopefully find ways to collaborate with him. Before we let you off though, I'm going to ask you what we sometimes ask our guests, what Ginger and I talk a lot about in our own personal lives is that once we understood about ACEs and early childhood trauma, we couldn't we couldn't unsee what we'd already seen, right? At this
Mm.
point. So, how has your personal life changed due to knowing what you know
Wow.
about ACEs and trauma?
I love this question because you're just so spot on I think why many of us have been transformed by this work.
Mm-hmm.
You're absolutely right because when I started getting into this topic, I started noticing the dynamics of my own relationships
Mm-hmm.
shift. And so the first place I saw it shift was my marriage.
Right.
I started to approach conflict with my wife differently, which softened her, and so she reciprocated that to me, and that was really healing in our marriage. It also shifted my parenting approach, where I could understand my child better from a developmental lens, and that sounds crazy to me because I was a pediatrician. Like I should have known all this.
No, well,
But I mean, we still talk about sleep training, right? In the AAP,
mm,
and so like there's still things that pediatrics hasn't caught up to as a we haven't had that paradigm shift that we need yet. It shifted my relationship with my parents, where
Mm,
I could kind of contextualize our dynamics, the unhealthy patterns in our relationship, my relationship with them from through a lens of understanding what they went through as children. And they were both children in post-Korean War Korea, um, who whose parents had been traumatized by the war, by a country that had previously been occupied by Japan, and then when it went straight into a war that they weren't fools. They knew the that this war was kind of a proxy of the Cold War at the time for
mhm.
between the Soviet Union and the Allied nations. So um, it shifted so many dynamics of my own relationships, and yeah, absolutely, that's when I knew I can't go back.
No.
And then the last thing I'll say is it shifted even my own faith, like as a person of faith, and because I mentioned grace earlier, like the idea of grace, and
Yes.
it just took a whole the idea of grace took on a whole, it just a much deeper meaning for me when I saw that, oh my gosh, the science is reflecting the power of grace in a human encounter as healing. It kind of helped me to double down on it, as a real core value for me. Um, so yeah, that's I love that question because it continues. I feel like I continue to experience the fruit from being trauma informed, from being relationally connected, from thinking about my own self-regulation, from thinking about my integration within, between, beyond. On so many levels, it's been tremendous for my personal well-being.
That's what a fantastic answer and way to wrap this interview up. Although I think I want to talk to you for like the next 2 weeks.
Me too.
We can do it again. Yeah.
But yes,
Yeah.
thank you so much today. And I know that our listeners are going to take away so much richness from everything that you've said, and also inspiration that the medical field is changing. We're going to say that and claim it, right? The medical
Yes.
field
Yes.
is changing.
Yes.
So we appreciate you and all that you're doing, and we appreciate our listeners as always. Thank you all. We'll catch you next time.
Thanks for joining us today for Regulated and Relational. Next time, we are replaying episode 99, which is about joy and joy stalking. You don't want to miss it. And remember, season 6 launches in January. A special thanks to Joe Kramer for donating the music. To learn more about the Attachment and Trauma Network, visit us at www.attachedtrauma.org. I'm Lauren Cassis, and as always, thanks for listening.